the skin of your abdomen, it creates this cave, this area that is dark and closed off and moist, and yeast loves that. So you can get this red rash that itches. It's hard to control. Baby powder is like a great way to fight it, but sometimes you just need like an antibiotic, like topical to really treat it. So definitely don't sit on that. Now, benign cysts, I have a lot of women that come to me and say, "Oh, I've just told I have lumpy breasts or cystic breasts or whatnot." It's certainly not a bad thing. It's more annoying than anything. In fact, 50% of women have experienced fibrocystic changes. Now, if you Google that, it'll come up fibrocystic disease, fibrocystic changes of the breast. There's a lot of different terms for the same thing. And what it really means is those lateral edges of the breast, there are sacs that have fluid in it, and they're very sensitive to hormones. So if you're in a higher hormone state, it will fill with fluid more for some women. And for those women, it becomes painful because they get filled with fluid, and then the hormones drop and the fluid goes away. So it's not necessarily you have to do anything about it, as much as it's bothersome for some people. So you can get a random abscess, typically not caused by anything, totally random. So I think I'm covering up the word trauma, but the real reason I mentioned that is if you have ever been hit in the breast or had some kind of trauma to your breast, it is very vascular. It gets very dark very quick, and it can take weeks for it to go away, but it does go away. And then benign tumors. So, like any place in your body, you can get a random tumor that's not cancer. And then, of course, cancer. So, that leads me to I would love to debunk some myths just for a second. So, myth wearing a bra causes cancer. Actually, there are studies that have debunked this. Like, we know that is not the case. Wearing a wire bra specifically does not cause cancer. Um, so please wear a bra. Support. Second myth, breast implants increase your risk of breast cancer. I actually get this one a lot. So breast implants themselves do not cause cancer. It's the fact that if you have an implant, it makes it more difficult to detect the cancer. So that's why screening is so important for those women. So another myth, only women with a family of, excuse me, with a family history of breast cancer are at risk for breast cancer. Actually, that's not true. Most women diagnosed with breast cancer have no family history. It's just that those women that have a family member, that person has a higher risk. So the fourth one is interesting, but I've definitely had people ask me, deodorants cause breast cancer, and that is not true. There's no research to prove that. An important one to me, the next one, is small breasts are less likely to develop cancer. I have had quite a few women make the decision not to get mammograms because they think they don't have enough breast tissue for it to matter. And that's not the case. It actually doesn't matter how much breast tissue you have, it still has the same risk. So, next one, breast cancer always causes a lump. So now a lump is the most common symptom, but there are other signs that can happen before a lump, like your skin can have a different appearance. One of the important ones is nipple discharge. You can also have what we call dimpling. It almost looks like the outside of an orange. But notice what I didn't say, and that is no pain. I get women like pretty regularly who come into the office asking if their breast pain is cancer. Cancer typically does not cause pain until it's further along, and you would know, like you would see it. So that's not a symptom. So if you ever have breast pain, take that out of your brain. It's not breast cancer. That's why I love to point out that muscle behind the breast, because usually it's that or that rib cage right behind that. So the last myth, mammograms are painful and dangerous. So mammograms cause discomfort because there's pressure, but it shouldn't be painful. And as far as danger, the radiation exposure from mammograms, it's low. It absolutely outweighs the benefit of not detecting an early cancer. And if you think about it, you get an x-ray of your teeth every year from the dentist. It is not much higher radiation exposure than that. Oh, I had to put a plug in for the Breast Health Center in Lakewood Ranch. If you live in Lakewood Ranch, the Breast Health Center is connected to the Lakewood Ranch Medical Center Hospital, and they are wonderful. They will guide you through every step of the way. Great women. So, talking about them, let's talk about breast screening. So, if you were to show up there or at another lovely mammogram center, what would you do? So, we're going to talk about breast exams and mammogram. So, when you turn 21 years old, that is when you should start having an annual breast exam completed. Now, I've had women come before 21 just because they want to know everything's normal, but you really should just start at 21 unless there's an issue. So, imaging, and when we mean imaging, I mean mammograms specifically. It either starts at 30 or 40 years old. 40 is for most people, and the decision to do 30 or 40 is totally dependent on your risk. Either you're low risk or you're high risk. And that's a calculation you determine with your doctor. And we'll talk about that a little bit more in a minute. So, if you're a low average risk patient, really, you just need annual breast exams and a mammogram. And that mammogram is every year. It starts at age 40 until 75. Now, that 75 number is a little controversial. The guidelines say it's a shared decision if you stop at 75. If you are 75, have no medical problems, living your best life, and if you got diagnosed with breast cancer, you would have it removed and move on, absolutely. Please keep doing your mammograms. But that is totally a decision between doctor and patient for sure. Now, high risk breast screening is definitely a little tricky because it's a calculator for most women, and I'll explain that. So, first, again, women at high risk of breast cancer, you start imaging at 30 years old, and we want imaging every 6 months. So, once a year, you get a mammogram, and then the 6 months in between, it's some kind of imaging. The recommendation is a breast MRI. That's the best we know. But some insurances won't cover it, and some women just prefer not to have an MRI. And if that's the case, I will do an ultrasound. But the goal is to have someone look inside the breast every 6 months. So, who's high risk? Like I said, there's this fancy long calculator that we use that helps us decide the lifetime risk of a woman. And if it's above 20%, then you're high risk. Now, a lot of mammogram reports have that percentage in there. So if you've had a mammogram, you should go back and look at it because I think they have to nowadays. If not, most of them just do. And that's helpful for the OBGYN ordering it because they've already done the calculator and I know what a patient needs. Now, that's the most common scenario for me as a gynecologist seeing a high risk breast cancer patient. But for the other, it's if you have a genetic mutation, specifically BRCA1 or 2, or if you have a first degree relative with that, or if you had chest radiation before 30 years old, or the last line is a few syndromes that are pretty rare. So let's camp out on dense breast for a second. This is a very hot topic right now. What does it mean, first of all? So, dense breasts, that is just a mammogram finding. This is the radiologist saying it is difficult to see the tissue because of the density of the imaging of the breast. So, before a few years ago, it didn't really, it didn't matter so much until the FDA came in and said now radiologists have to grade someone's density and then tell the patient and their doctor what the density was. So if you notice on your mammogram report, it will tell you how dense your breasts are. It'll say, there are different terms. It'll say like 0 to 25% density, 25 to 50, 50 to 75, or it might say severely dense or heterogeneously or mildly dense. There's all these different terms. No one's really using the same thing yet. But again, it's just an image finding, not so much like an anatomical finding. So how common is it? 50% of women in their 40s have dense breasts. So this is not like this small group of women have this issue. Half of women have this mammogram finding. The reason this matters is it has been found by research that if you have dense breasts, it can be more challenging to detect earlier breast cancers. It can hide it, if you will. So What do we do about it? Well, we don't really know yet. People are trying to figure that out. You might go to an OBGYN who tells you, oh, don't do anything, just get your mammogram every year. On the other hand, you might go to a different OBGYN who says, oh, you need a breast MRI as well. And that's an extreme other end. That's because we have no guidelines yet. Now they're working on it, they're trying to figure it out what to do. But there's not actually a right or wrong answer. And I just don't want you to think that there's something wrong with you if your report comes back dense breast. None of us really know what to do with it yet, but that just means there's more research down the line to help us. So I had to put one quick slide about dermography because it's around. So thermograms are FDA approved, but they're approved only because it's safe. They didn't actually approve it because it works, not on efficacy. So thermograms will detect cancer, but the whole goal of this is to detect cancer as early a stage as possible to reduce morbidity and mortality. And the studies haven't proved that it can do that. So that's why no major organization recommends it. In fact, I don't think anybody, like I said, any of the major guidelines organizations recommend it at this time. So I don't either. But I know there are still studies out there on it. So let's talk about what if your screening mammogram comes back abnormal? This is very scary for every single woman that gets that phone call, which is why I wanted to talk about it. So, what happens and what's next? What is a diagnostic mammogram? And what is the difference between that and a screening? So, when you have a screening mammogram, you go to the breast center, you have your mammogram completed, you leave, your images go to the radiologist at a later time, maybe the next day, maybe later that day. They read it, and then your doctor has sent the report. Okay. Then, if it's abnormal, which again, abnormal usually means they just can't see enough and they just need better images of an area. So, a diagnostic mammogram, you go back again to the breast center and you're getting the same images machine, but the radiologist is physically present and telling the technician, move the patient a little bit this way, I can't see this way. So it's a more dynamic mammogram. And usually you get an ultrasound at that time as well. But again, I just don't want you to think, oh, I have to get a diagnostic mammogram, I have cancer. That's not it at all, actually. Usually it's just they can't see an area very well. So let's talk a little bit of statistics. So if you get a diagnostic mammogram, again, this leads to, oh my gosh, do you have cancer? But I want you to remember these things. 10% of screening mammograms need diagnostic mammograms. That's 1 in 10 women. The radiologist could not see everything and they need extra pictures. Okay. Now, of that group, out of 1 of 10 women, 1 to 2% of diagnostic mammograms need a biopsy. So that is small. That is not very many women need a biopsy. And of those women that actually have a biopsy, 20% of them are cancer. So when you get that screening mammogram that comes back abnormal, I just want you to take a deep breath because you have this information now. So let's say you do have cancer, the biopsy proves it. The next step is go to the breast surgeon, who you're going to speak with next. But before we get there, I just want one more quick, kind of random but pertinent slide about what if you've had breast cancer and what do you do after you've had breast cancer and you're treated and you're done and you're over it and you come back to me, to your gynecologist. So you're going to still have an annual exam. If only part of a breast was removed or all of the breasts are removed, I still look at the area. You still have skin, you may still have breast tissue, you still have a chest. So I definitely think that's important. And as far as imaging, if you have any breast tissue left whatsoever, mammograms, you will still get mammograms. You may even get breast MRIs, depending on what your oncologist says. And then, really, one quick last is about hormone replacement therapy. When you get to menopause and you're having hot flashes and maybe some of those symptoms, and you want to know if you can have HRT, if you've ever had breast cancer, even if it's hormone negative, usually gynecologists won't prescribe hormone replacement therapy. Even if you're hormone negative cancer, the thought is that woman is still at risk for another cancer, and they don't want to confound that with hormones. Now, in saying that, Don't be sad because there are medicines that are coming out that have come out to help women in this exact situation. Maybe 3 or 4 years ago, a new medicine came out specifically for hot flashes, vasomotor symptoms, for this situation. I actually have women use it that haven't had breast cancer. They just don't want hormones. So, lots of options still. And it's still worth going to a gynecologist because you still need it. We still need an exam. So, um, I guess from that point on, I'll hand it over to the breast cancer surgeon. These are my references. In fact, I'm going to point out densebreast-info.org. If anyone has any questions about dense breasts, this is the best website ever. It is up to date. It's really good. And then this is just how you find me.
That was amazing. First of all,
Thank
I learned
you.
so much. And, from somebody who usually has to have a diagnostic after my screening, just knowing those stats. And I know every woman out there can relate to that. Just you breaking that piece down was like a big sigh of relief. And I don't, if we're not asking, maybe the doctor usually isn't sharing that. And definitely when you're getting the mammogram, nobody's sharing that with you, right? It's just not
And
part of it.
then you get from the time you had a screening mammogram to the diagnostic, it could be weeks. And so then you're
Yes.
sitting there worried for weeks that it's
In your head.
cancer.
Yes, that's so
So
true.
I just want to give women like some peace of mind here. Just remember the radiologist just couldn't see everything. Okay. That's it. That's it. Just keep that in your head.
Yeah, absolutely. I love that. Well, and I think I learned, so much more. I took notes. You talked about diet. I thought that was a great highlight. I think a lot of us do neglect that. We are busy, a lot of moving parts in our lives. So that was a great reminder. I'll have to watch this again. And the Mythbusters, are you kidding me? Like that took me back to my childhood. I was like, wait, I might have believed one or two of
I think
those.
some of that is on TikTok actually. So yeah.
Is it? Yes.
Yes.
Okay. No, for sure. We won't
Yes.
give away my age, but that's amazing. Well, thank you, Dr. Eden. We'll move over to what happens next. So, Dr. Sam, we'll let you take the stage and
Thank
we'll take a
you.
back seat here. Thank you so much.
All right. Up. Let's see. Add the stage. All right. There we go. Well, thank you all for joining. This is a topic that's near and dear to my heart. I've had several family members that have survived breast cancer, and I really enjoy doing breast cancer surgery because it's one of the few cancers that I do that actually has a really good survival rate. I typically tell most people if you get your annual mammograms and you catch these cancers early, I expect you to live your whole life, and that's something fun to be able to share with people, especially when they get a diagnosis of cancer, that you can get through this and we will walk you through it. And so that's what we wanted to talk about today, is kind of as when Dr. Eden talked about, once you have that abnormal mammogram, what do you do next? That's typically when I get involved. And so the talk today is mainly just a surgical perspective on breast cancer. So we'll kind of go over some of the same stuff she went over, just to briefly touch on it. But early detection is very important. It's one of the most common cancers among women. Mammograms definitely the key to early detection, and we're going to focus on what's next after you have that abnormal mammogram. So, definition of an abnormal mammogram is just a mammogram that shows a suspicious area. There's several things we look at with the radiologist, the gynecologist, and me, is masses, calcifications, and asymmetry. Those are the main important things that would lead you to getting a diagnostic mammogram. And I always tell people not all masses are cancers, but they do need further evaluation, and that's where I come into play. So this is what just a mass looks like on a mammogram. You can see the center area where all the arrows are pointing, not the white one, but the one in the center with the orange and the red. That's just a mass found on mammogram. These are calcifications. You can see the one on the left is kind of the zoomed out view, and the one on the right is the zoomed in view. They're just little small white dots. We call them calcifications. And then this is just asymmetry. You can see the area in the top right of the breast. It just looks asymmetrical, and that's why I call it asymmetry. So when you typically get a diagnosis or a mass on mammogram, that's typically when you're sent to me. And so when you first come see me, we'll kind of go over everything about our first meeting. I like to lay it all out. what the whole process is going to look like. We'll take a detailed history of some of the lifetime risk stratifications that Dr. Eden talked about. I won't go into all those, they're listed right there. And we'll also take a history of any of the symptoms you've been having, such as masses, lumps, skin changes, axillary adenopathy, that just means swelling in your armpits, nipple discharge, nipple changes. And then we'll discuss the findings and areas of concern on your mammogram. And then, as Dr. Eden talked about, the next step, diagnostic imaging. That's the diagnostic mammogram and ultrasound. I just tell people it's a fancy mammogram where they're able to zoom in on the areas of concern to get more information of them. You can also, some people need an MRI for the high risk or complex patients. And then with all those, you get what they call a BIRAD score. It says BIRDAS, it's BIRAS, it's the Breast Imaging Reporting and Data System. And it's just a standardized system that's used in breast imaging to detect the likelihood of cancer. And so we'll kind of go over all these. So BIRAD 0 just means it's incomplete and it needs further imaging. There's no cancer likelihood to this just because it's unknown. The next is a BIRADS 1, which is negative. That's a good thing. It's a normal, no abnormal findings are present. The likelihood of cancer is pretty much 0, and they just recommend routine screening mammogram, which is 1 year. A 2 is benign findings. That just means there's something there, but it's typically a cyst or a fibroadenoma, which are benign. Low likelihood of cancer, pretty much 0, and just routine screening as well. So 1 and 2, just routine screening. And when you get to the 3, that's when it starts to change kind of the management. The likelihood is that it's benign is good. It's still a very low chance of cancer, but it is recommended that we have an earlier follow-up, typically 6 months after your mammogram that showed the BIRADS 3 finding, and then we'll do that for 2 years just to make sure there's no changes. And then when you start getting to the 4, this is when it's suspicious for cancer and a biopsy is recommended. So anyone with a 4 and above, or a 4 and a 5 technically, you're going to get a biopsy after this. And that's where I kind of start taking the reins of things. The cancer likelihood's 2 to 95%, and that's broken down into 4A, 4B, and 4C. You can see the likelihood of a 4A is 2 to 10%, pretty low suspicion for cancer. The likelihood of a 4B, 10 to 50, and a 4C is 50 to 95. And all of these are recommended that you have a biopsy done. And a BIRADS 5, highly suggestive of malignancy or cancer, and likely 95% chance or greater, and also biopsy recommended. And then this next one says BIRADS 5 again, but it's technically supposed to be a BIRADS 6, which means it's a known cancer. So biopsy, next critical step. Once a BIRADS 4 or greater is found, the next thing we need to get is a tissue diagnosis, and there's several ways we can do that. The standard is getting a cord needle biopsy, which is done under mammogram or ultrasound guidance by the radiologist, and they make a small little incision. They take multiple biopsies with a large needle. You are awake during this, but they can give you medicines to help you kind of relax. But this way, it allows you to get a small tissue through a small incision. In case it is a benign finding, you can avoid scars and the need for surgery. There are some indications for a surgical biopsy. The majority of it's people who are just nervous and want to get the mass removed. But sometimes if you have breast augmentation, sometimes it can be too close to the implants, and they recommend a surgical excision for the biopsy. And then it typically takes 1 to 2 weeks for the pathology to return once you get that. So once you get the pathology report, you have one more follow-up with me. We kind of go over the differences in these right here. They can be anywhere from benign, which are the listed. There's a bunch of different benign findings. Not all of them need surgery. Some of them do need surgery because they can upgrade to cancers or precancerous lesions such as ductal carcinoma in situ or lobular carcinoma in situ, which just means, I look at it very simply. There's the lobules in the ducts where the milk is made and where it goes to the nipple. And a ductal carcinoma in situ just means there are suspicious cells or precancerous cells, but they're contained to the duct. And when you have a malignancy or cancer, that just means those cancer cells are spread outside the duct or the lobule. And so there's several things that go into the conversation of what does your pathology show. They have the different grades, which just describes 1 through 3, how much the cancer cells differentiate from normal breast tissue. This is done by a pathologist. And the grade 1, 2, and 3, one's low grade, well differentiated. They're very, very low aggression, low likelihood of spreading. Grade 2 is kind of in between grade 3 and grade 1. Grade 3 is poorly differentiated or high grade, and they look very different and have a high chance of spread. And like I said, 2 is just kind of in between those. And then another thing we look at from a surgery and a kind of a preoperative and postoperative standpoint based on your treatment is the receptor status. Kind of like Dr. Eden talked about, there's all these different hormones that change the breast tissue, and some of breast cancers, the most common, or most of them have some type of receptor that's helping it grow, whether it be estrogen, progesterone, the HER2 receptor. And then you have some that don't have any of them. Those are called triple negative. And these help us guide our plans as to when to do surgery or chemotherapy or anti-endocrine therapy, sometimes before or after surgery. The final stage of the tumor, that's what gives you your true stage. The grade's not a stage. The stage of the tumor typically has to have surgery done because it needs the size of the mass, which is done at surgery. We find out when I send it to a pathologist. You get lymph node status because we take some lymph nodes. And then also with imaging prior to that, we can tell if it's gone anywhere else. Those are the 3 main categories that determine your, we call it the TNM stage, but it's just the stage. And then once you have the diagnosis of cancer under pathology, you'll see several of us. You'll see me, I'll send you to a medical oncologist, a radiation oncologist if you need radiation or if you're getting a lumpectomy, and a plastic surgeon if you're going to be getting a mastectomy with reconstruction. Depending on the type of cancer you have, based on the receptor status, the size, and certain indications, surgery can come first. Sometimes chemotherapy or anti-endocrine therapy has to come first, or sometimes it comes afterwards. And like I said, plus or minus radiation, depending on if you get a lumpectomy. So that leads us into who needs chemotherapy before surgery. These are very broad categories. It actually goes much more in depth based on your pathology, and me and the medical oncologist kind of have a discussion about that. But large tumors typically need chemotherapy before surgery to help shrink it down. Aggressive tumors such as the triple negative or the HER2 positive tumors, locally advanced breast cancer, inflammatory breast cancer, the need to evaluate tumor response, high risk features, or if a person has a large tumor and desires breast conserving therapy or surgery. Helps shrink it down so you can do that. So the difference between the surgical options they offer, sure, most everyone's familiar with lumpectomies and mastectomies, but the lumpectomy would just take the breast cancer with a small margin, and it helps leave a smaller incision. You get to keep the nipple, and it keeps the natural shape and texture of the breast. And a mastectomy takes the entire breast tissue and is typically followed by immediate or delayed plastic surgery reconstruction. On both of these surgeries, we do what we call sentinel lymph node biopsy, and that's where we inject a radioactive tracer and a blue dye to try and find the first 2 to 3 lymph nodes that drain from the breast tissue, and we take those out of the armpit, sometimes through the same incision, sometimes through a separate incision, and that helps us evaluate if it's spread to the lymph nodes or not. And then like I said, some people are not candidates for each. This is kind of where I come into play. Sometimes it's up to the person whether they want a lumpectomy or a mastectomy, but sometimes people are not candidates for lumpectomies or what we call breast conserving therapy. Those are the large tumors that are compared to the breast tissue, because if we try and do a lumpectomy on a large tumor with small breasts, it'll leave it distorted. Multiple tumors in different quadrants. We kind of see the breast as a quadrant with 4 quadrants, the upper outers and the lower outer and inner and upper inner as well. And if it goes over multiple quadrants, typically you need a mastectomy. Also high-risk patients such as the BRCA1 and 2 people. Anyone who's had a radiation contraindication, like I said, all lumpectomies for cancer follow with radiation after surgery. And if the contraindications are typically previous, you've had previous lumpectomies and radiation or previous chest radiation for something else. Patient preference, like I said, inflammatory breast cancer and recurrent after breast conserving therapy. And then the surgical treatment options, again, both lumpectomy and mastectomy are outpatient surgeries, and you get to go home the same day. Sometimes, depending on reconstruction, you may have to stay after a mastectomy, just depending on the type of reconstruction you get. The lumpectomy is typically a 45-minute surgery. Mastectomies can be 1 to 3 hours, just depending on if it's unilateral, bilateral, and what reconstruction's done. And then what to expect after surgery. So, like we talked about, outpatient surgery, go home the same day. I'll send you home with some pain medications that are taken by mouth if you need them. Some people do, some people don't. You can shower the same day. You'll have waterproof glue over most of your incisions. You just can't do any heavy lifting for 2 weeks. And if you have a mastectomy, typically we leave drains just to help get all the fluid out of there. And we'll teach you how to do those before you leave. And then you'll follow up with me in 2 weeks at my clinic. And we'll review your pathology, do a wound check, and then set you up with further consultations with either the radiation or medical oncologist if you haven't already had those. And then after surgery, we'll have your final stage based on the pathology. Like I said, that includes the tumor size, the lymph node involvement, and if it's gone anywhere else. And that helps us really guide what to do next if you had upfront surgery. So I use the NCCN guidelines. That's our national cancer guidelines that most everyone around the country uses to just treat breast cancer the same nationwide. Some people will not need chemotherapy after surgery, and some people will. It's based on your pathology. If you do have a lumpectomy, like I talked about, you will need radiation therapy to the affected breast. A lot of people will need anti-endocrine therapy, or most everyone will need anti-endocrine therapy depending on your receptor type. And then after you've had all your treatment done, you've had radiation, chemotherapy, or just surgery, whichever combination you have, you go into what we call surveillance. And the long-term surveillance is typically seeing me and the medical oncologist alternating every 3 to 6 months for 5 years. You'll get your breast exams and a wellness exam. We'll go over anti-endocrine therapy symptoms, answer any questions you have, help you get set up with support groups. We'll also set you up with your yearly mammogram starting 1 year after surgery, and then mammograms and ultrasounds and potentially alternating MRI if high risk. And start you setting up with bone density testings every 1 to 2 years. Go over lifestyle changes to reduce recurrence, which are very similar to what Dr. Eden talked about. And then once you're done with this, you get to go back into the regular screening pool. But I typically will see my patients every year just to go over their mammograms as well. So the lifestyle changes to reduce recurrence: healthy diet, regular exercise, maintain a healthy weight, limit alcohol consumption, avoid smoking, reduce stress, focus on mental health, sleep well, avoid hormone replacement therapy, and excuse me. And then another thing that's very under looked at, but is very important, is the emotional and psychosocial or psychological support. Mental health and emotional support is key to success. You have to take care of yourself during this, and you also need friends and family to help you with that as well. I can help set you up with resources such as support groups and counseling. And the most important thing is getting your family and community involved during your recovery. It's let them be a part of it. A lot of people sometimes want to try and do this alone. And I say the most important thing is just having the best support group you can and letting them be a part of it, because most of those people want to be a part of it as well. Like I said, the journey of breast cancer from diagnosis to recovery is unique to each patient. I do want to be there with you every step of the way. I'll call you, you can call me your quarterback through the whole process. And as I tell everyone, the moment you get diagnosed, we'll get through this together, and you can do it. So if you have any questions, we'll be more than happy to answer them. Once again, thank you so much for coming. We're really excited to get this going, and I hope that's helpful. You're muted, Amanda.
I just love, thank you, first of all, again, amazing.
Yeah,
I just love, in that moment, it's pretty scary. Even like Eden said, in between a screening and a diagnosis, your mind just plays a lot of games with you. So I love that you're the quarterback, and I'm sure I can hear you explaining that to all your patients. So I think that's important. And the emotional piece, so glad you brought that up, because, when there's uncertainty in our world, it creates a lot of fear. And we all lean on God, to give him the fear. But I know it's very hard when you're in the moment, and there's a lot of moving parts with that. So I just thought that was a great way to put it, that you're the quarterback in the uncertainty. That was great. Yes. Yeah. So any connections there, you two, kind of listening to each other even, anything to add or clarify?
No, I think I really liked what Eden covered. I mean, you'll see Dr. Eden and I mean, we're very integral, just like with either your GYN or a primary care doctor. We all work as a team, and so everyone is very aware of what's going on, and that's why there is some overlap in our slides, just because it's hard for one person to touch. I mean, truly, it's hard to not talk about the whole picture, either from the surgery side or the primary care or GYN side, just because it's such an integrated process, and we all work together and kind of know how to do the same thing. So it's a fun process just because we get to work so intimately with each other and with our patients, and you get to follow them for so long. It becomes a real joy to be able to take care of cancer patients.
Yeah, it's like the whole team.
Yeah, yeah, yeah.
Yeah, for sure.
Yeah,
I love
and
that.
it is a team effort. Like it's,
Mm.
gosh, no matter what kind of cancer it is, for me that for a patient, I love walking with her through it, even though I'm not going to be removing that breast cancer. She's still my patient, and I still want to be there, and I still want um, to know how she's doing because she's still the rest of her body still needs to be healthy. She has an emotional state as she's going through it, and I love that. I for me, I've never actually heard Dr. Sam, what you say to people and what your counseling is. And I know that some people, the first thing they do is Google, which is not a bad thing. Dr. Google is most of the time not wrong. I mean, there's some crazy stuff, but it's not the worst, but it's how do you filter out everything that's on the internet and be able to take a deep breath and say, okay, this is what I know. And I feel like everything that you said really just brought to focus what was important because there's so much extra stuff, if that makes sense,
Yes.
on the internet. And I love that. I love what you had to say.
I love it. We've got some comments too saying great insights, and I agree. And I think this is rare. This is why I'm so excited about the wellness journey and us, kind of all coming together because I don't think we get this a lot. When we come to see you in the office, there's not always, sometimes we even clam up, right?
Yeah.
As the patient, saying from the
I
patient.
do that too.
Yeah.
I do that when I'm
Oh, I wish I would have asked that. Why didn't I ask that? So
Yeah.
I think this is an amazing platform. And then we also have a comment too saying, glad to know that the two of you are with people going through this. And that's what, I always say Dr. Sam and Dr. Eden are like a big hug. And I'm currently not their patient at all, but just being around them as humans, they're just amazing. So I think, the industry is better off with you in it. And we just, thank you for sharing this insight. A couple of little things I just want to ask you before we kind of wind this down. Probably going back to Dr. Eden, your slides first. When you talked about diet, what about, and not necessarily hormones, I guess, but supplements? Is there anything that helps breast health with supplements? And that's just, kind of a broad statement, I know, but anything there?
Yeah, so a lot of the research that has to do with supplements or vitamins really has to do more so with breast cancer in hopes of trying to find anything that will reduce that risk of breast cancer. A lot of them are used for other reasons too, so a lot of women are probably already on it, but one of the main ones is vitamin D, which I highly recommend anyone in perimenopause and in menopause to be on that, which by the way, I will be giving another webinar on perimenopause in like a month. So please come.
Coming in November.
That's what I'm very passionate about, is talking about perimenopause. But really, vitamin D, we know reduces the risk of breast cancer. And then a lot of the other vitamins, it's really just about the antioxidant properties that they have, like vitamin E, vitamin C, which, I mean, you can get that from citrus and things, but both of those are usually in just like a women's vitamin. So if you're not on it, think about taking a women's vitamin. So you would look for vitamin D, EC, vitamin A is in all women's vitamins pretty much. One that's not typically, but is important for your heart as well, is omega-3 fatty acids. Now you can get vitamin D and omega-3 fatty acids together as a supplement. So that's one way to do that. So you're not taking 1,000 supplements, right? If you can just be on a women's vitamin and then a vitamin D omega-3 fatty acid, that'll cover a lot of it. Really, The only other one is iodine, but that's not typically something that we need to supplement necessarily in the United States. There may be some of that in a women's vitamin though, but again, just a women's vitamin and a vitamin D omega-3 fatty acid, which has so many other benefits too. That's what I recommend.
Awesome. That's great. Now, see, I don't even think I knew the vitamin D part at all, like as far as breast health.
Yeah.
Yeah, that's completely new information. So I'm glad I asked. I want to go just one deeper, then let's just pretend I'm in your office with you, right?
Okay.
And
All right.
101. One supplement I hear a lot about right now is ashwagandha, or am I even saying that right? And that's, you said antioxidant, right? So maybe something like that overall, or does that have any, is there anything
Well,
else?
if you think about it, like the Mediterranean diet is an antioxidant diet, right? That's all it
Got it.
is. That is
Yep.
all it is. So if you are taking a supplement that's truly an antioxidant, like you're not going to do anything but help yourself, to be honest. Now you can go down the list of all the antioxidants and OD on blueberries, but really, you don't have to go that hard. But if you're just because you don't want to over supplement either, you can actually take too much
Yeah.
vitamin A. You really can. So if you're just taking like the natural supplement, excuse me, the like women's vitamin supplement a day, that's usually enough. Now, the one that you mentioned, you just have to be careful that what's in there is just that. Like, I'll have some
Mm.
women, they'll come sometimes with their bag of vitamins and they don't realize that like three of their vitamins all have vitamin C. And then
Oh,
they drink orange juice every morning. So,
so it's too much. Yeah.
you
Yeah.
just
Yeah.
have to make sure you know what's in it. That's all. But the thing about vitamins, if you're trying to give yourself breast health or reduce breast cancer, is you're never going to feel that change, right? Like you're never going to say,
Yeah.
"Oh, my vitamin D is working. I feel so healthier from a breast
My breast feels so
standpoint."
healthy. I love that.
Right? No, you're not. But if you're taking those things for perimenopause, which I'm not trying to get into the next month's webinar, but if you take them for symptoms, you're going to know in like a month. So if you're taking your antioxidants for other reasons, like you're wanting to look at your skin, you're wanting to look at how you feel, after like 4 to 6 weeks, you should know if it's doing something for you. But again, what I was talking about, the vitamins, you're never going to feel the difference. You just know that they're reducing your risk of cancer. And it's not just breast cancer, it's others too.
Yeah. So good. So good. Yes. Now I can't wait to talk perimenopause because, some of us have been there.
No,
We can relate. So I'm excited about
you
that.
did it.
Is that November 13th? We're doing that one, right?
November
8 p.m.
13th,
Yeah. We'll get information out to you guys
8
too. So
p.m.
make sure you join us for that. Okay. So Dr. Sam, on yours, like time frame, I guess, I come to you. So it's a serious conversation at that point. Say there is going to be a surgery. Like what's the time frame ish, right? From I'm just thinking about the emotional health piece from meeting you, determining that game plan, etc., to the surgery, so to say. You're muted.
Yeah, there you go. Got it. I saw it.
We both
It's
have done that.
yeah. It really just depends on your specific tumor on the pathology. So, say you have upfront surgery is what your tumor will allow, and you want a lumpectomy. You're looking at 1 to 2 weeks out from the initial consultation to getting surgery. It's usually pretty easy to get someone on quick. Mastectomy sometimes can take a little bit longer, maybe I say 1 to 3 weeks, just because you have to also go meet with a plastic surgeon as well to have that consultation. And then we have to line 2 schedules up versus just one when it's just a lumpectomy with me. And it's one thing to mention too, a lot of people think a mastectomy has a higher survival rate than a lumpectomy, just because if you take the whole breast tissue, you
I
should
would
have
totally
a better
think
survival.
that.
But there's no difference in the survival. And so I just tell people that the smaller incision with the lumpectomy, you get to keep your natural breast tissue and contour of it, and it has the same outcomes and results as far as the survival. But some people, they don't want them there anymore. They want them gone, and that's totally understandable. And so insurance covers all of it, whether it's a choice of mastectomy versus lumpectomy. So, but typically 1 to 2 weeks to get you on surgery, and then depending on if you need chemotherapy before, anti-endocrine therapy before, sometimes it can be months to a year before you're getting surgery. But that's to help have a better outcome if you need that up front.
if you need that. Yeah, that's great. Well, no, I think that helps. Just, if anybody's
Yeah.
in that seat kind of wondering, or
Hmm.
becomes to be one of your patients.
Hmm.
I think that's helpful. All
Yeah.
right, well, let me check the chat here, see if we got any other last minute questions. I think that's all of them here. Yeah, maybe let's just wrap it up. Again, everyone, thank you, and I'll let you two kind of speak, and just about the community and how you hope to see it grow, and then we can wind down for the night.
Yeah, so I'm really excited about the wellness journey. The whole point of the wellness journey is to have one space where people can come, truly be a part of this community, just to learn more about their health. Like as a gynecologist, I have all this information that I went to school for and I trained for, and that was a privilege. But now I feel like all women should have that information. It shouldn't be, let's go on Google and decipher what's right, or social media. I want women to have information. I want to empower women with information about their health so they can
Love
take
that.
that information to their doctor and be knowledgeable in the conversation with their doctor. So I'm not trying to take you on doctor's place. I just want to give women more knowledge. And that's where I come from in the wellness journey, just to be more well, having more good information.
Love it. Yes, Dr. Sam.
I just love how this has all happened. So I'm, only half of my patients are females, and this is kind of Amanda and Eden's creation. But I've gotten to be a part of the journey, just watching God just put on their heart the want to, like Eden said, empower women and teach them more, educate them more, encourage them spiritually. And I'm just super excited to get to be a part of it. I can't wait to do some more stuff and just see what God has in store for us as this journey continues.
Yes, I'm so excited. And I'll just add to that a little bit. Eden and I started talking about how you guys don't have a lot of time with your patients sometimes, and there's so much more to give. And I do think that's kind of what created this space, right? Was where is a space that can be that neutral, where you can be a little bit more informative and relational too, as well, because we don't always get to see our doctors in this light. So thank you for taking the risk, so to say, right? And putting yourselves out there. It's greatly appreciated. And I am completely excited to see what you guys want to hear about too, right? We've got two amazing doctors here. I'm going to be more of the mindset life coaching. That's who I am and what I do. But we would love to hear from you and what topics you want to kind of tap into. Perimenopause and menopause are coming your way. But there's so much more: men's health, women's health, mindset, everything. We can cover it all. We can bring other guests if you have anyone to suggest. So we want you to be a part of this as well. And again, thank you for being here. I thought this was amazing. I took lots of notes, and I am more informed, I know. So we will see you next month. Join our Facebook page. I believe it is in the chat. And if you're watching this on replay, it'll definitely be in the caption. And we'll see you in November.
Thank you. Bye, everybody.
Yeah.
Bye.
Thank y'all.